consideration of microscopic examination of urine is that the microscopic examination is a valuable diagnostic tool for the detection and evaluation of renal and urinary tract disorders and other systemic diseases. So the principle of this examination is that the microscopic elements present in urine are collected in the form of deposit by centrifugation. A small drop of the sediment is examined by making a cover slip preparation under microscope. So before proceeding for examination, specimen must be evaluated in terms of its acceptability. Number 1. Minimum labeling requirements. Patient's full name, date and time of collection. Number 2. Intactness. There shouldn't be any leakage, spillage, and damage to container. Number 3. Timing of collection. First voided morning urine is the best for routine analysis. Number 4. Preferences. If multiple investigations are to be done from a single specimen, bacteriologic examination should be performed first. Hence, volume of urine should be noted properly. In order to perform this examination, we need centrifuge tube or test tube, glass slide, cover slips, pasture pipettes, centrifuge, microscope, and a freshly voided urine specimen. Mix the urine and pour into a centrifuge tube until it is 3/4 filled. Centrifuge with another balanced test tube for 5 minutes at 2,500 revolutions per minute. Pour off the supernatant quickly and complete into another test tube. This can be used for protein determination. Resuspend the deposits by shaking the tube. Place 1 drop of the deposits on a glass slide. Cover it with cover slip and mark it with identification number. Observe it first under low power objective in partially closing the diaphragm and then adjusting the condenser downward until satisfactory contrast is obtained. Note the content of various fields. Switch to high dry objective and observe at least 10 to 15 different fields.
Urinary crystals. Crystals frequently found in the urine are rarely of clinical significance, appear as true geometrically formed structures or as amorphous crystals. Crystal formation. Crystals are formed by the precipitation of urine solutes, including inorganic salts, organic compounds, and medication, heterogenic compounds. General identification techniques. pH, appearance in acidic or alkaline urine, use of polarized microscopy and solubility characteristics of the crystals. Normal crystals seen in acidic urine. Urates, consisting of amorphous urates, uric acid, acid urates, and sodium urates. Amorphous urates. Yellow-brown granules may occur in clumps resembling casts and attach to other sediment structures. Uric acid crystals. pH less than 5.5. Shape varies from rhombic, four-sided flat plates or whetstones, wedges, and rosettes. Usually appear yellow-brown, but may be colorless and have a six-sided shape. Acid urates, sodium urates, rarely encountered, appear as larger granules and may have spicules. Calcium oxalate crystals, frequently seen, can be found in neutral urine. Dihydrate, colorless octahedral envelope or as two pyramids joined at their bases. Normal crystals seen in alkaline urine. Phosphates include amorphous phosphate, triple phosphate, and calcium phosphate. Amorphous phosphate, granular in appearance, similar to amorphous urines. Triple phosphate or ammonium magnesium phosphate, prism shape that frequently resembles a coffin lid, may develop a feathery appearance as they disintegrate. Calcium phosphate crystals, not frequently encountered and may appear colorless, flat rectangular plates or thin prisms. Calcium carbonate crystals, small and colorless, with dumbbell or spherical shapes. Ammonium biurate crystals, yellow-brown color of urate crystals, frequently described as thorny apples or spicle-covered spheres. Abnormal urine crystals are found in acidic urine or rarely in neutral urine. Cystine crystal, found in the urine of persons with cystinuria, appear as colorless hexagonal plates and may be thick or thin. Only thick cystine crystals have polarizing ability. Cholesterol crystals, rarely seen unless refrigerated, resembles a rectangular plate with a notch in one or more corners, associated with disorders producing lipiduria. Radiographic dye crystals have a very similar appearance to cholesterol crystals and also highly birefringent. Differentiation. Comparison of the other urinalysis results and patient history. Elevated specific gravity. Crystals associated with liver disorders. Tyrosine crystals, fine, colorless to yellow needles, frequently form clumps or rosettes. Leucine crystals, yellow to brown spheres that demonstrate concentric circles and radial striations, less frequently seen than tyrosine crystals. When present, should be accompanied by tyrosine crystals. Bilirubin crystals appear as clumped needles or granules with the characteristic yellow color of bilirubin, present in hepatic disorders. Sulfonamide crystals, shapes, needles, rhombics, whetstones, sheaves of wheat, and rosettes. Colors, colorless to yellow-brown. Ampicillin crystals appear as colorless needles that tend to form bundles following refrigeration. Urinary sediment artifacts. The most frequently encountered artifacts include starch, oil droplets, air bubbles, pollen grains, fibers, and fecal contamination. Starch granule contamination occur when cornstarch is the powder used in powdered gloves. Highly refractile spheres, usually dimpled center, resembles fat droplets when polarized. Oil droplets and air bubbles, highly refractile and may resemble RBCs. Oil droplets may result. Air bubbles may occur when using cover slip. Pollen grains, seasonal contaminants, appear as spheres with a cell wall and occasional concentric circles. Hair and fibers, from clothing and diapers, usually longer and more refractile. Fecal artifacts may appear as plant and meat fibers or as brown amorphous materials.
RBC or red blood cells appears as a smooth, non-nucleated and biconcave disc. It is measured approximately 7 mm in diameter. It is identified using a high-power objective, and it is reported as an average number per 10 high-power fields. In concentrated urine or hyperstenuria, the cells shrink due to the loss of water and it may appear conated or irregularly shaped. Dilute urine or hypostenuria, the cells absorb water, swell, and lyse rapidly, releasing their hemoglobin and leaving only the cell membrane. These large empty cells are called ghost cells. RBCs are the most difficult to recognize. Lack of characteristic structures, variation in size, and close resemblance to other sediment constituents. RBC is frequently confused with yeast cell, oil droplets, and air bubble. Yeast cells exhibit budding. RBC is smaller than WBC or white blood cells. RBCs that vary in size have cellular protrusions or are fragmented, termed dysmorphic. It is associated primarily with glomerular bleeding. Clinical significance of red blood cells. The presence of RBCs in the urine is associated with damage to the glomerular membrane or vascular injury within the genitourinary tract. The number of cells present is indicative of the extent of the damage or injury. White blood cells or WBC. WBCs are larger than red blood cells. These measure an average of 12 mm in diameter. The predominant WBC found in urine is neutrophils. Neutrophils is much easier to find than RBCs. WBC is also identified using a high-power microscopy. It is also reported as average per 10 high-power fields. Neutrophils exposed to hypotonic urine absorb water and swell. Brownian movement of the granules within these larger cells produces a sparkling appearance, called glitter cells. Have no pathologic significance. Eosinophil may also be present in the urine. The presence of urinary eosinophils is primarily associated with drug-induced interstitial nephritis, where small numbers of eosinophils may also be seen with urinary tract infection and renal transplant rejection. If the finding is more than 1% eosinophils, it is considered significant. Mononuclear cells include lymphocyte, monocyte, macrophage, and histocyte. It may be present in small numbers. Lymphocytes is the smallest WBC. They may be resembles RBCs. Monocyte, macrophage, histocytes are large cells may appear vacuolated or contain inclusions. The primary concern in the identification of WBC is the differentiation of mononuclear cells and disintegrating neutrophils from renal tubular epithelial cells. Fewer than 5 leukocytes per high-power field are found in the normal urine. Higher numbers may be present in the urine from females. An increase in urinary WBCs is called pyuria and indicates the presence of infection or inflammation in the genitourinary system. Bacterial infection including pyelonephritis, prostatitis, and urethritis are frequent cause of pyuria. Pyuria is also present in non-bacterial disorders such as glomerulonephritis, lupus, interstitial nephritis, and tumor. Reporting the presence of bacteria in a specimen containing leukocytes is important.
Yeast. It is a small and has a refractile oval structure. It appears branched and mycelial form in severe infection. Budding yeast cell differs from red blood cells. Candida albicans, seen in urine of a diabetic patient, immunocompromised patients, and women with vaginal moniliasis. A true yeast infection should be accompanied by the presence of white blood cells. It is reported as rare, few, moderate, or many for high power.
Bacteria. Bacteria are not normally present in urine. A few bacteria are usually present as a result of vaginal urethral, external genitalia, or collection container contamination. These contaminant bacteria multiply rapidly in a specimen that remain at room temperature for an extended period, but are of no clinical significance. They may produce a positive nitrate test result and also frequently result in a pH above 8. Bacteria may be present in the form of cocci or bacilli. To be considered significant for UTI, bacteria should be accompanied by WBCs. Specimen containing increased bacteria and leukocyte are routinely followed up with a specimen for quantitative urine culture. The actual bacteria producing an UTI cannot be identified with the microscopic examination. Parasite. The most frequent parasite encountered in the urine is Trichomonas vaginalis. Trichomonas vaginalis is a fruit-shaped, flagellate with an endowing membrane. It's easily identified in wet preparation of the urine sediment by its rapid darting movement in the microscopic field. Trichomonas vaginalis is a sexual transmitted pathogen associated primarily with vaginal inflammation. Infection of the male urethra and prostate is asymptomatic. The ova of the bladder parasite Schistosoma hematobium will appear in the urine. Fecal contamination of a urine specimen will also result in the presence of ova from intestinal parasite in the urine sediment. The most common contaminant is ova from the pinworm Enterobius vermicularis.
Spermatozoa. Spermatozoa are easily identified in the urine sediment by their oval, slightly tapered heads and long flagella-like tails. Urine is toxic to spermatozoa, therefore, they rarely exhibit the motility observed when examining a semen specimen. Spermatozoa are occasionally found in the urine both men and women following sexual intercourse, masturbation, or nocturnal emission. Spermatozoa are rarely of clinical significance except in cases of male infertility or retrograde ejaculation in which sperms are expelled into the bladder instead of the urethra. A positive reagent strip test for protein may be seen when increased amounts of semen are present. Laboratory protocols may vary with regard to reporting or not reporting the presence of a spermatozoa in a urine specimen. Mucus. Mucus is a protein material produced by the glands and epithelial cells of the lower genitourinary tract and the RTE cells. Uromodulin is a major constituent of mucus. Uromodulin is a glycoprotein excreted by the RTE cells of the distal convoluted tubules and upper collecting ducts. Mucus appears microscopically as thread-like structures with a low refractive index. Subdued light is required when using bright field microscopy. Mucus is more frequently present in female urine specimens. It has no clinical significance when present in either female or male urine.
Urinary cast. They are a cylindrical aggregation of particles that form in the distal nephron, dislodge, and pass into the urine. In urinary cysts, they indicate kidney disease. They form via precipitation of thumb horse full mucoprotein, which is secreted by renal tubule cell. The urinary casts have two classifications: the cellular cast and acellular cast. In a cellular cast have hyaline, granular, and waxy cast, and in a acellular cast have red cell cast, white cell cast, epithelial cast, and fatty cast. First is cellular cast. Number 1 is hyaline cast. The most common type of cast. The hyaline cast are solidified thumb horse ball mucoprotein secreted from the tubular epithelial cell, seen in fever and after strenuous exercise. Number 2 is granular cast. The granular cast can result from breakdown of cellular cast or the inclusion of aggregate of plasma protein or immunoglobulin light chain, indicative of chronic kidney disease. And number 3, waxy cast. The waxy cast suggests long-standing kidney disease. And second is acellular cast. Number 1 is red blood cell cast. The presence of red blood cell cast within the cast is always pathologic and strongly indicative of glomerular damage. They are usually associated with nephritic syndrome. Number 2 is white blood cell cast, indicative of inflammation or infection, pyelonephritis, acute allergic intestinal nephritis, nephrotic syndrome, and post-streptococcal acute glomerulonephritis. Number 3 is epithelial cast. This cast is formed by inclusion or adhesion of desquamated epithelial cell of the tubule lining, seen in acute tubular necrosis and toxic ingestion, such as from mercury, diethylene glycol, or salicylate. And last is fatty cast, formed by the breakdown of lipid-rich epithelial cell. These are hyaline cast, with fat globule inclusion present in nephrotic syndrome, diabetic, or lupus nephropathy, acute tubular necrosis.